Every week, someone sits across from me and describes the same picture. Burning under the heel after 30 minutes on a hard floor, stabbing pain with the first steps of the morning, a heaviness in the feet by afternoon that simply was not there 5 years ago. And every single one of them has the same explanation ready. Aging. They are half right. Something is changing, but it is not random, and it is not inevitable, and it is not what they think. 5 structural changes begin degrading the foot after 50 in ways that are entirely predictable and largely preventable. The mistake is not that people ignore their feet. The mistake is that nobody tells them what is actually happening inside them. Before any of these 5 changes can be understood, the foot itself needs a moment of honest attention. Most people treat it as an afterthought, the part of the body furthest from the face and furthest from consideration. That is a serious error in priority. The human foot contains 26 bones and 33 joints. It is not a rigid platform. It is a dynamic mechanical system designed to absorb load, adapt to surface irregularities, generate propulsive force, and transmit balance information to the brain in real time. With every walking step, it absorbs roughly 1.5 times your body weight. Descend a flight of stairs, and that number climbs to 3 times your body weight, concentrated through the heel and the ball of the foot. When that system is intact, you do not think about your feet. When it begins to degrade, you think about very little else. Here is the critical point. These 5 changes do not arrive randomly. They arrive in predictable sequence, driven by the intersection of biological aging and the cumulative mechanical demand placed on a structure that has been loaded millions of times. Understanding the sequence is what makes prevention possible. The first change is fat pad atrophy. Beneath the heel and beneath the ball of the foot sits a layer of specialized fatty tissue organized into small fibrous compartments. This structure is called the plantar fat pad, and it functions as the body's primary ground impact shock absorber. When your heel strikes the ground with each step, this pad compresses, spreads, and absorbs the impact before it reaches bone. Between the ages of 40 and 80, the plantar fat pad loses roughly 30% of its original thickness. That does not sound catastrophic on paper. In practice, it means the bone is closer to the ground. There is less material interrupting the shock wave that travels upward through the skeleton with every stride. This is the direct mechanical explanation for the burning, bruised sensation so many people over 50 describe after walking on tile or concrete. Not inflammation from overuse, not nerve damage, bone impact on a hard surface with insufficient cushioning between them. The fat pad cannot regenerate, but the consequences of its loss can be substantially reduced, and that correction begins with understanding what is actually missing, not with buying the thickest insole available and hoping for the best. The second change is arch collapse, which carries the clinical name adult-acquired flat foot deformity. The medial arch, the inner curve of the foot visible in a normal footprint, is not maintained by bone shape alone. It is actively held in position by a structure called the posterior tibial tendon. That is the primary structural cable running along the inside of the ankle, connecting the calf musculature to the bones of the midfoot, under load with every single step. After 50, this tendon progressively weakens and elongates. As it does, the arch it was holding begins to flatten. The foot pronates, that means it rolls inward at the ankle, and the load angle across the entire lower limb shifts. What follows is not a local foot problem. It is a chain reaction. When the ankle rolls inward, the knee follows. The kneecap drifts off its intended tracking path. The hip compensates for the altered mechanics below it. The lumbar spine absorbs the residual stress at the top of the chain. Patients come to me with chronic lower back pain that began with a tendon in their ankle. By the time they arrive, they have seen 2 or 3 specialists, and not one of them examined the foot. That is not an accident. That is a system that treats locations, not chains. The posterior tibial tendon responds to targeted mechanical load. Arch-supporting structures can be strengthened in their early stages of failure. But none of that happens when the cause is misidentified, when the back is treated and the foot is ignored. Here is what that means in practice. The foot and the spine are not separate systems. They are the same system, organized vertically. A failure at the base of the chain does not stay at the base. It travels. And by the time it announces itself at the top, the origin point has been loaded incorrectly for months or years. That is the picture I see over and over again. And that is exactly why no one tells you about it at a standard appointment. Because addressing the chain requires starting at the bottom, and the bottom is not where the pain is. The third change is toe deformity progression. The two most common forms are hallux valgus, that is the clinical term for a bunion, and hammer toe, a condition where one or more of the smaller toes develop a permanent downward contracture at the middle joint. These are not cosmetic problems. They are mechanical failures with measurable consequences for how you walk. Hallux valgus develops when the big toe is chronically forced inward toward the smaller toes. Two forces drive that deviation simultaneously. The intrinsic foot muscles, the small muscles housed entirely within the foot, weaken and lose their ability to hold the toe in correct alignment. And narrow footwear applies continuous compressive force across the forefoot, accelerating the drift. Over years, the base of the big toe shifts outward, producing the visible bony prominence. What most people never consider is what that drift does to the mechanics of walking. The toe-off phase, the final moment of each stride when the big toe presses against the ground and propels the body forward, depends entirely on correct alignment and muscular strength at that joint. When hallux valgus disrupts that alignment, propulsive efficiency drops with every step. The body compensates by redirecting load to the lesser toes and the outer forefoot. Neither structure is designed to carry that burden. That compensation accelerates deformity in the exact tissues absorbing the redirected force. One mechanical deviation becomes a distributed failure across the entire front of the foot. The fourth change is plantar fasciitis, and it demands particular attention. Not because it is the most structurally complex change on this list, but because it is the one that most clearly reveals how the previous three changes interact. The plantar fascia is a thick band of connective tissue running from the heel bone to the bases of the toes along the sole of the foot. Its function is to support the arch dynamically during the push-off phase of each stride, acting as a tension cable that stores and releases elastic energy. Inflammation of this structure is the most common cause of heel pain in adults over 50. The reason is not mystery. It is accumulation. By the mid-50s, three of the changes already described are typically present at once. The fat pad has thinned, increasing mechanical shock at the heel with every step. The arch has begun to flatten, placing the fascia under chronic stretch beyond its resting length. The calf muscles, shortened from years of sitting and insufficient stretching, pull the heel bone upward through the Achilles tendon and increase tensile load on the fascia from above. That is not one problem. That is three forces converging on a single structure. And it explains precisely the symptom that nearly every plantar fasciitis patient describes before they understand the diagnosis. The pain is worst with the first steps of the morning. During sleep, the foot rests with the toes pointed slightly downward, and the fascia contracts into a shortened, rested state. The moment full body weight loads that cold, contracted tissue, already under chronic tension from arch collapse and calf tightness, already losing the cushioning protection of an intact fat pad, the tensile stress spikes sharply. That is not mystery pain. That is a predictable mechanical event. And treating the fascia in isolation, without addressing the arch, the fat pad, and the calf, is why so many people spend months on a treatment protocol that produces only partial relief. The fifth change is intrinsic foot muscle atrophy, and it is the change that receives the least clinical attention despite having the broadest downstream consequences. Intrinsic muscles are the small muscles that originate and insert entirely within the foot itself. They control toe splay, manage fine adjustments to arch stiffness during the stance phase of walking, and execute the rapid balance corrections that prevent falls on uneven surfaces. They are the foot's internal stabilization system. After 50, two forces work against them simultaneously. Natural age-related muscle atrophy reduces their volume and contractile strength, and conventional cushioned footwear functions as a mechanical splint. When a thick, structured sole carries the load the foot's own muscles would otherwise manage, those muscles receive no neuromuscular demand. They are not recruited. They do not contract. Over years of walking in heavily cushioned footwear, the intrinsic muscles weaken from disuse in exactly the way any unloaded muscle weakens. That is not a design flaw in the shoe. That is simple physiology. Use it or lose it is not a motivational phrase. It is a description of how muscle tissue responds to the absence of demand. The consequences appear first as reduced balance, particularly on uneven surfaces. Proprioception, the body's continuous sense of its own position and movement in space, depends partly on sensory signals generated by the foot's contact with the ground and the active engagement of the muscles responding to that contact. When intrinsic muscle activity diminishes and a thick sole interrupts direct ground contact feedback, proprioceptive sensitivity degrades. The brain receives less precise spatial information. Balance corrections arrive more slowly. The risk of a misstep on irregular pavement, a wet surface, or an unexpected step edge rises measurably. After 50, when the vestibular system, the balance and orientation system housed in the inner ear, is already operating with slightly reduced precision, that additional proprioceptive loss is not a minor inconvenience. It is a compounding deficit. A fall after 50 is not getting up, brushing off, and continuing. It frequently means a fractured wrist, fractured ribs, or a hip fracture. And a hip fracture after 60 means surgery, extended immobilization, and a rehabilitation period measured in months, not weeks. 5 changes. Different anatomical locations, different clinical names, different presenting symptoms. 1 failing system. And the question every patient eventually reaches, usually after trying 2 or 3 partial solutions that did not hold, is the same. Should I switch to barefoot shoes? It seems like a logical conclusion. Remove the cushioning that is suppressing the muscles. Restore ground contact. Let the foot do what it was designed to do. The logic is not wrong. The application, for most people over 50, is. Atrophied muscles do not respond to sudden full loading by growing stronger. They fail. Stress fractures develop in the metatarsal bones, the long bones running through the midfoot, because the intrinsic muscles that would normally absorb and distribute ground reaction force are not strong enough to do so. The posterior tibial tendon, already weakened by progressive arch collapse, is placed under abrupt increased demand and develops tendinopathy. That is, degenerative tissue breakdown within the tendon itself. The plantar fascia, already inflamed, is loaded without the protective compression of a cushioned sole and worsens. These are not theoretical risks. They are the injuries that appear in clinical practice with consistent regularity in patients who read an article, purchased minimalist shoes, and began walking 5 miles a day in them the following week. The transition failed not because the destination was wrong. It failed because the rate of loading exceeded what the current structural state could tolerate. That is not a failure of the philosophy. That is a failure of sequencing. The evidence on gradual minimalist transition is clear. Studies examining foot muscle cross-sectional area, the actual volume of muscle tissue measured by imaging, show measurable increases after 12 weeks of deliberate, progressive, minimalist shoe use. The intrinsic muscles respond to restored neuromuscular demand. Proprioceptive sensitivity improves. Arch-supporting muscle activity increases. But those outcomes depend entirely on one word: gradual. 12 weeks of progressive loading, beginning with short durations on forgiving surfaces, increasing exposure incrementally as the muscles adapt. Not 12 days. Not a single weekend footwear purchase followed by immediate full use. The correct answer to the barefoot question is this: neither maximum cushioning nor immediate barefoot walking is universally correct. That is not ambiguity. That is precision. The correct intervention is matched to 3 variables: the individual's current structural state, the planned transition timeline, and the surface type on which they walk most frequently. A person with significant fat pad atrophy and active plantar fasciitis requires cushioning during the transition period, even while beginning intrinsic muscle training. A person with mild arch flattening and no fascial inflammation may tolerate a faster minimalist progression on grass or a rubberized surface before advancing to pavement. Knowing which category applies to you requires examination, not a trend, and not a blanket clinical recommendation applied to every foot that presents with pain. Now, a clear, practical conclusion. Here is exactly what to do. 1. Address fat pad atrophy directly. Replace walking shoes that are more than 12 months old, regardless of how intact the outer sole appears. The cushioning material in the midsole, the layer between the rubber base and the inner lining, loses its shock-absorbing properties long before the shoe shows visible wear. That is not a commercial recommendation. That is bone protection. 2. Load the posterior tibial tendon deliberately. Single leg heel raises. Stand on one foot. Rise onto the toes. Lower slowly. 3 sets of 10 on each side daily. This directly strengthens the primary structural cable holding the medial arch. 3. Address plantar fasciitis at the source, not the symptom. Before your first steps each morning, while still seated, pull your toes gently back toward your shin and hold for 30 seconds. This stretches the fascia before it is loaded cold. It costs 30 seconds. It prevents the morning spike. 4. Begin intrinsic muscle training. Remove your shoes for 20 minutes each day on a textured surface. Spread your toes deliberately. These are not exercises for athletes. They are neuromuscular maintenance for a system that conventional footwear has placed in long-term disuse. 5. If minimalist footwear is the goal, begin with 1 hour per day on a soft surface for the first 4 weeks. Increase by 30 minutes per week. Do not progress to pavement until 60 minutes on grass produces no foot fatigue. If pain appears, reduce load and hold that level for 2 additional weeks before advancing. Here is the clinical reality that ties everything together. All 5 of these changes carry consequences that are 2 to 3 times more serious after 50 than they would be at 30. The fat pad does not regenerate. The posterior tibial tendon heals more slowly once damaged. The plantar fascia, once chronically inflamed, requires longer to settle. The same mechanical neglect the body absorbed without consequence at 35 generates real, persistent, compounding symptoms at 55. Not because you changed anything, because your tissues changed. And the window for prevention, for addressing these changes before they produce the symptoms that bring most patients into my office, is not infinite. It narrows with each year of continued loading on a system that is not being maintained. How old are you? Write it in the comments. I want to know which stage of this process this material is reaching you at, so I can focus future content on exactly where you are right now. Walking is one of the most accessible and effective tools available for maintaining health after 50. But a walk built on a degrading mechanical foundation does not deliver the benefit it should. It delivers compensation. And compensation, repeated daily over years, accumulates into the injuries and chronic pain that fill clinical waiting rooms. Nobody at a standard appointment is going to explain the structural state of your foot and trace your symptoms back through 5 interconnected changes to their mechanical origin. That is not how that system operates. It profits from managing consequences, not from preventing them. That is exactly why this channel exists. Subscribe to Dr. Waterling, leave a like on this video, and help us reach 100,000 subscribers. Every single one counts.